Intravascular DIC or disseminated intravascular coagulation. Just have an idea, we discuss it more in case of coagulation. We talk about disorder of bleeding disorder. We come back to disseminated intravascular coagulation. So for now, we just cite it as an element. What we need to understand here, it's just there will be overconsumption of platelets and coagulation. There will be formation of microthrombi in damage to the red cell membrane. Then the detail we see in the part of coagulation. Next, we have what we call paroxysmal nocturnal hemoglobinuria. Why paroxysmal? It's like episodical attacks, which nocturnal because it occur mostly in the night. Then the patient may come in the morning and say, in the morning I'm seeing blood in my urine, red urine, or Coca-Cola urine in the morning. So it's what you can call Marchavaccia Michelli syndrome. It's not common, it's very rare. It's usually due to mutation on the gene, which is called PIGA genes, which is really coding for the red blood cell membrane protein. So red blood cell membrane protein usually this protein avoids the complement activation to the red cells. So when there is a deficiency in that membrane, that will make the red cell exposed to the complement activation, then there will be increase of risk of having hemolysis. So one moment, I have to answer an urgent call. Sorry. Hello? Mugira scan. Wamubwiye akayisikana ntabwo ndi CHP munsi akanyohereza muri email yanjye. Araza kwishura agwe mumuhe kopi iri hard copy. Wowe wanyohereza kuri email soft. Yakoze arayifite email. Nyandeze. Kamali ni ngomba kusinya wayimushira kasinya Dr. Kamali yari ese ninde usinya undize. Kamali namara gusinya wa scanner utere ukashira CHK then you scan it. Ari kindi arondo isinya na undi isinya. Ngewe ntabwo nsinya ntabwo turi babiri dusinya. Ayinyoze kuri imbere merci. Mumbwire abikore vuba. So, sorry for disturbing. So, it usually occurs at the age of 30 to 40. The patient will have intravascular hemolysis with negative cause. Then, as we said, the episode will be occurring during the night. Then the patient will come morning. Mostly say it's due to hypoxemia during the night, but the key mechanism is not really known. Those also have increased risk of venous thrombosis, may have a DVT or pulmonary embolism and other symptoms of iron deficiency, bone marrow failure, but also some of the patients may have risk of developing acute leukemia. How do you treat it? The patient in a future of intravascular hemolysis, we have nocturnal hemoglobinuria. Then we have a positive acidified serum lysis test, which really is targeting how the membrane responds to the stress. That will be suggesting that the patient may have a deficiency in red blood cell membrane. Then we have also hemocystinuria. So my arrangement is just to transfuse in case of severe anemia. folic acid therapy. Patients with chronic hemolysis, they need to get supplement in efficacy because there's a turnover in the use of folic acid in case of hemolysis. We say that iron, after hemolysis, iron will go back to erythropoiesis, but for folic acid, you to sample it more so the patient does not have risk of folic acid deficiency. So if it has iron deficiency, you can treat also iron deficiency. Then expecting that that might be immune-related issue, they may give also steroids. But the treatment is to do stem cells transplantation. So that is all for mice. The next topic is aplastic anemia. By aplastic anemia, you understand what we call pancytopenia. So among the cause of pancytopenia, we have also aplastic anemia. It's not all the pancytopenia is aplastic anemia. So by definition, aplastic anemia, it's a condition where there's pancytopenia, meaning decrease in all the cells, red cell, white cell, and platelets, with decreased bone marrow cellularity, with no other abnormal bone marrow findings. So the bone marrow is not able to produce cells, but when you go to check on the bone marrow, you find abnormal findings which explain why the bone marrow is not able to produce cells. Among the etiologies, we have 50% is primary, that it is idiopathic, speculating that it might be autoimmune or congenital and hereditary. So here it's not clear to know which exact mechanism of that. Then 50% you may find the causes, either drug medication or chemicals, radiation, infection, or other condition like paroxysmal nocturnal hemoglobinuria or red cell aplasia. That is in 50%. So here again, autoimmune is 50% or idiopathic without clear causes. This is the list of indication which may cause secondary aplastic anemia. Among them, we have those dependent. We have like a cytotoxic, example methotrexate, melphalan, anti-inflammatory like diclofenac, and so on. For diabetes, penicillamine. So this is the list of all medication. Meaning that that's why again got the history asking the medication the patient is taking. It's really very crucial when you're seeing a patient with aplastic anemia. Then chemical exposure to organophosphate insecticides, agrochemicals. So working in agriculture area without better manipulation of the products may be exposed to have aplastic anemia. Exposure to any ionization, atom bomb, or people working in radiology, like radiologists, scientists, and so on, but also after radiotherapy. But we have any cancer during the cancer treatment, they may look aplastic anemia as side effect as from radiotherapy. Other etiology might be infection. We have hepatitis, we have virus, HIV, parvovirus, and so on. So what is the mechanism of aplastic anemia? At the beginning, told that there is no any known cause of aplastic anemia, but there is some speculation which may think that either there is a direct toxicity effect on the stem cell or the stem cell as defective. Maybe the microenvironment of the bone marrow is not favoring cell production, or colony factor stimulating conditions or other immunological aspects. So again, those are speculation. The clear mechanism is not clear. So age, any age can be affected, but especially on the young age, people around 30. Some studies show that there is no difference between male and female, but there are some who show that there is male predominance. The prevalence could drop maker. It's usually around 2 to 5 cases per 106 per year. Then in Africa, it looks like the cases are common, but a lot of age data for now. But still, when you consider the risk factors in Africa, in terms of high exposure to those uh, risk factor like chemical, where people are manipulating things without knowing how to keep them, how to use them, risk of infection like HIV, hepatitis, all might explain the issue with the aplastic anemia. Mm, stories. So I lost my slide. Uh, what are the signs of and symptoms of anemia? If you understand the mechanism of this, what will be the manifestation of aplastic anemia? We can guess. How can someone with aplastic anemia present?
like bleeding.
So be very systematic. Explain this because of this. This because of this. This because. So start by bleeding due to what?
Acute fever, fever due to low white
Hmm?
blood cells, fever due to low blood cell, white blood cells,
So the
can
patient
have
will be having fever due to low production of white blood cells. That's one. Second,
uh, she will be fatigue and tiredness due to anemia,
hmm? Yeah, due to anemia.
and breathing uh, due to low platelets.
Great. So those are the three things that will be the patient will be struggling with three things. So bleeding, anemia, future of bleeding, future of anemia, and future of infection. That will be classical symptom and signs. So what else apart on the physical exam? Normally, aplastic anemia is defined by the pancytopenia, but when you go to the physical examination, there is no splenomegaly, there is no hepatomegaly, there's no lymph node. If you see partial lymph node, hepatosplenomegaly, whatever, think about other causes of pancytopenia, not aplastic anemia. Correct? So how do you make the diagnosis? Who can guess us? How do you make the diagnosis of aplastic anemia? Of course, you ask for the full blood count, which will show you decrease white cell, decrease hemoglobin, decrease in platelets. So what is the key exam to do?
Bone marrow biopsy.
For what?
So bone marrow biopsy would be showing you that. So the exam is placytopenia on the full blood count. Then the peripheral blood film will be confirming pancytopenia. Anemia will be normocytic, normochromic. Sometimes they see increase of lymphocytes compared to the rest. There will be decreased reticulocytes. So again, decreased production from the bone marrow is reflected by decrease of reticulocyte count. There will be bone marrow aspiration, which will show you decreased airity. You may do dry or blood tap, meaning that when you do the aspiration, you don't get any bone marrow particles. There'll be predominance of fat cell, increase of lymphocyte and plasmacyte. So bone marrow biopsy is the one to confirm the diagnosis, where you'll be having hypocellularity with fat cells. You have spares hematopoietic element, then the image I showed you before, it's the one which is there. So remember the image I showed you before? The red marrow becoming fat with the decrease active, which is the red marrow not producing. So the pathologist, when you biopsy, will be able to tell you in these patients the bone marrow, the active bone marrow is around 5%, 10%, 20%, 3%. So it estimates which percentage of the bone marrow is active producing cells. So that's how the diagnosis is made. So different diagnosis. Remember to mention all the conditions which may cause pancytopenia. We have bone marrow infiltration by leukemias, lymphomas, or any other cancers, TB, myelofibrosis. So any infiltration by the infiltration of the bone marrow by cancer, infection. They may also have a neoplastic anemia. We can have myelodysplasia or paroxysmal hemoglobinea and so on. So this is the condition which may cause aplastic anemia. Then the other is to do the chromosomal testing to check for test for the cause of secondary causes. So also think about screening of infection, think about any medication, any exposure, and so on. So this will be how to call it. So clinic criteria for diagnosis of severe aplastic anemia. Now it's the main of thing. My patient is having aplastic anemia, but is it severe or not severe? So the severity will be depending on any one of the following in the bone marrow. So from the peripheral blood film, the following: neutrophil below 0.5, platelet 20, reticulocytes below 1%. From the bone marrow, one of the severe hypocellularity or increase of 25% from normal cells or moderate hypocellularity with less than 30% of hematopoietic cells. So again, here as we say, there may be increase of lymphocyte, plasma cell, and this in such condition there will be poor prognosis of such condition. So I'm having some technical issue to solve. So this, I was saying that severe plastic anemia will cause poor prognosis. So how do we manage it? First of all, it is to remove if there is any secondary causes. How to address the causes, if it is medication, if it's radiation, and so on. You have to identify the causative agent and remove it. We have to consider treatment of infection with antibiotics. Then you consider also blood component therapy because the patient may die from either severe infection or severe media bleeding, which may kill the patient. So again, blood transfusion will be supportive treatment. Sometimes we consider it like immune system, induced aplastic anemia. We give high dose steroids and anti-lymphocyte globulin to combine with the cyclosporin to see the response. So, but the curative treatment is to do bone marrow transplantation. So, young people who can get financial support, but also not only financial, but also we can get sibling or any matching donor. So again, it's two things together: financially and donor issue. Then also we consider the application of the young age who can get a donor, who can have some sibling who may meet the HLA system. They may get easily bone marrow transplantation. Another kind of anemia is what we call Faconese anemia or Faconese syndrome, which was first described by someone from Swiss pediatrician called Guido Fracconi in three brothers who were presenting with pancytopenia. So when they go deep on that, they found that the issue was only like a plastic anemia, but it was somehow related to the defect in DNA repairment. So that may be that was like a autosomal recessive disorders presenting that defect in DNA repairment. So apart having anemia, they also having other abnormalities like skeletals, like skin issues, renal and so on. So that may have also mental retardation. So again, Fanconi anemia, most of them are around 5 to 10 years old, but it may also occur at any age. Then 10% may develop acute myeloid leukemia transformation. Again, the treatment is somehow similar to aplastic anemia. So that was, we can say. We have also another condition which is called non-Fanconi hereditary anemia, which is called Diamond-Flaccan syndrome. It's also a rare disease which is occur in the first year of the life with the congenital abnormalities of anemia. There is usually depleted in erythroid precursors in the bone marrow. So it usually affects red blood cell precursors. The rest are okay. Platelet and white cell are all normal. The treatment is just a transfusion of red cell, but also it may also associate with the other disease like the skeletals congenital. They may also present type of anemia due to genetical issues, not only from the issue having seen from the bone marrow. So this is all for aplastic anemia. We can ask the question when I finish all the anemia. Meanwhile, I keep moving. We go to go to sideroblastic anemia. Sideroblastic anemia, we'll just make a quick reminder. Qualitative defect of globin chain synthesis result in hemoglobinopathy, which is a sickle cell diseases. For quantitative defect of globin chain result in thalassemia. We have defect of portion resulting in porphyria. Then we have a defect involving recuperation of iron into M molecules that in sideroblastic anemia. So, what is sideroblastic anemia? It's a group of the diseases which is due to failure to use iron in the hemoglobin synthesis despite having inadequate iron steroids. So here again, the mechanism is just iron available, but the iron is not able to go inside of red cell precursor to produce hemoglobin. So the disease is it has a remarkable marking signs which we call ringed sideroblasts. So those are the erythrocytes. Call them ring because they have the position of iron in perinuclear of their membrane. So you see the 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 iron is not able to enter in the mitochondrium. They stay on the Golgi outside. So you will see those granules on the membrane on the nucleus, which is sideroblasts. Maybe I can show you the picture. So how will be so ring sideroblast is the hallmark of the disease. As I told you, we use Prussian stain to see the iron component in the red cells in the bone marrow. So according to the iron deficiency, the iron is abundant in the bone marrow, but in iron deficiency, the absence of iron in the bone marrow. So this is the what we call ring sideroblast. So here you see class of red cell, they see the deposition of iron, which is in blue there, blue inside, outside there, outside class you see the blue, those are the one we call ring, they call it ring sideroblast because it is sent to the ring, earring or whatever, so that's why they call it. So the analysis is specially made on bone marrow as a biopsy where you do Prussian blue stain to see how the the erythroblasts look like. So it can be the hereditary, which is X-link. It can be isolated genetic syndrome. It may also be autosomal. In acquired, it may either due to drugs. Some medication may be like a chloramphenicol is used with chief in TB treatment. It may also due to heavy exposure to heavy metals lead or therapy agent, or it can be just a clonal proliferation of ring sideroblasts. So signs and symptoms, the patient will have a future of anemia, fatigue, and so on. Things which will be somehow remarkable, as we said, we have said that 75% of iron is dedicated for erythropoiesis, but here we say the iron is not used, so meaning that there will be a tendency to have iron overload in the body. So when there is iron overload, there will be tendency of iron deposition to some organs like a liver, like the heart causing cardiomyopathies and so on. So there'll be the secondary symptoms of organ failure due to excess of iron storage on that one. So what is the damage you should do doing FBC full blood count CBC complete blood cells? Blood cells you have to see from the bone marrow, which help you to see the ring sideroblast by doing Prussian blue, but also you have to check on parameters. You check uh, the hemoglobin, serum iron, and serum transferrin, and so on. How do you treat it? Again, you have to consider if is it hereditary form. They may respond to vitamin B6, expecting that the mechanism is it's like enzymatic path which is missing on incorporating iron precursor nucleus. So here again, vitamin B6 will help that. So again, if it is a secondary, you should consider the causative agent. Is it a toxin? Is it exposure to heavy metal and so on? Lead poisoning, it also causes the cell syndromic. The reticulocyte can be increased or decreased. Then sideroblastic is very energetics. It's the mechanism is the same, either hereditary or it also can be acquired due to medication, toxin, and so on. Then the is like that. So again, the mechanism, remember, it's just when the entry of the iron into the mitochondrium of the red blood precursor is blocked due to deficiency in enzyme M2A. Then the iron will be accumulating in the mitochondrium, causing deposition on the nucleus. You have seen the ring sideroblast. As the iron is not used as primary erythropoiesis, there will be increased iron, increase normal to decrease transferrin, and increase ferritin in severe cases that may cause also organ dysfunction. So that's what we have for sideroblastic anemia. So let's talk about globinopathy, where we have sickle cell disease and thalassemia. I think most of the pathophysiology we have make it really genetic. Is it right? So it's a blood disorder which characterized by the red blood cells that assume abnormal, rigid, which are sickle-shaped red cells. The shape of the red cells make the red blood cell to lose their flexibility and their elasticity to move through the blood vessel. So their movement are somehow restricted. Then that's make them not providing enough tissue
We are not
supply
seeing the
in
slides. Sorry, we are not seeing the
oxygen.
slides.
Let me share it again. Can you see the slide?
Yes.
Can you see it now? Can you see the slide?
Yes.
Yeah. So sickle cell again. We have sickle cell diseases, which group sickle cell trait and sickle cell anemia. As we said, sickle cell anemia is related to the hemoglobin SS. Then the pathophysiology should be due to sickle-shaped red cell lose their flexibility. They have restricted movement through the blood vessel, and sometimes they may cause vaso-occlusion. So by causing vaso-occlusive, they may cause a crisis, which will be reflected by poor oxygen supply to the tissue behind the the occlusion, so there will be having a future of ischemia, pain, or organ damage if it is taking longer. The spleen may also be affected. So, according to WHO, sickle cell is somehow high. Prevalence is 2.5 worldwide. Then some areas are affected by having even up to 25%. So, in more than 300 babies, 300,000 babies with severe hemoglobin were born per year, especially in some of the countries. So in the US, the prevalence is mostly among the African American of 8%. We have high cost to the disease follow-up and management. In Africa, you see the prevalence may even raise to 30% of sickle cell traits, with the Nigeria being the highest incidence in Africa, where they can have 45,000 to 90,000 babies per year who's having sickle cell. In Africa, again, in South Africa, it's somehow higher, but because also they have immigrants across the country. So sickle cell is usually split by sickle cell is an hemolytic anemia disorder which was described by Eric where one of the acetaminase is replaced by valine is replaced glutamic acid is replaced by valine on the sixth position. I think you remember the pathophysiology. Uh, it's on the short arm of chromosome 11. So by that change of one acidic amino acid to another one cause absence of a polar amino acid at position of this position, which make the cell to lose their shape and to lose their elasticity, making them the central issue on the pathophysiology of sickle cell. So, as we have lab genetics, pathophysiology, we have understand that there is a stressor which precipitates the crisis. Among the stressors, we have cold exposure to cold weather, we have hypoxia, infection, dehydration, acidosis, stress, pregnancy, alcohol. Those are the stressors or precipitate factor which may induce sickle cell crisis. To have someone with that one to have the crisis. So sickle cell can be sickling, where we may have 5 to 50% of total red blood cell that may cause severe hemolytic anemia. They have a recent membrane more rigid in sickle states was occlusion, so which may cause permanent pain. We have decrease in nitric oxide, which cause free hemoglobin in the plasma due to hemolysis. Then we have also hypoxia, which decreases NO production, nitric oxide production. So we have also increased viscosity due to vaso-occlusion. So we have said about the countries which have high risk of high number of sickle cell. We have Angola, DRC, Nigeria. Sometimes you may not see a known history of a family history because sometimes you may just see a parent being presenting sickle cell traits, so you may not have clear family history, and some they are not aware of their condition. So hematologic abnormality are present earlier, especially starting from the age of 6 to 12 months. Why? It's just because from the age of 6 to 12 months, where the fetal hemoglobin is starting to decrease. From the 0 to 6 months, there is protection from the fetal hemoglobin. So manifestation, we have three major things where we have hemolytic anemia, we have a vaso-occlusive crisis manifested by pain episode. Then you have a multiple organ tissue damage due to micro effects. So that will like a long-term complication of cell. By hemolytic anemia, we have a process of hemolytic shortening of the lifespan below 120, which lead to intravascular hemolysis. The patient will present future of hemolysis by having pallor or whatever. They have accelerated life metabolic because they have a chronic activation of bone marrow, and the bone marrow is not able to make it like for a long time. That's why liver and the spleen will also take over to produce the cells. So the patient may have a hepatosplenomegaly. Vaso-occlusive crisis, remember the pain crisis. You have to measure how frequency is the pain per year, because if someone is having like a 2 episodes of pain a year, that's like a severe sickle cell, then the treatment may differ depending on the frequency of vaso-occlusive crisis. So we may have mild to severe, we may have areas spontaneous or triggered by stressors. They may also have pain in the legs, on the arm, the chest, and also sometimes we may also have bone marrow involvement where the we have severe bone pain in the mesothelium, the spleen, priapies, and so on. So you have to assess the pain episodes quickly. The person may also have what called heart syndrome, which is that's the swelling of the hands and the foot, which may be when the small vessels are blocked. This is also a sign of severity when it occurs below the age of 1 year. As those patients have hypofunctioning of the spleen, so risk of having infection on streptococcus and Haemophilus influenzae, Listeria meningitis, and so on. And the infection are the major cause of death in the sickle cell patients. So for the vaso-occlusive crisis, patient mentioned have acute chest syndrome, which usually due to pulmonary infection. The patient will present with severe chest pain, fever, hypoxia. Sometimes you may confuse with pneumonia, but when you go to the X-rays and the breaking down, you also the laboratory markers of infection. That's where you may think about syndrome. They may also have cerebrovascular occlusion due to the vaccine complication. So 11% of them will develop CVA by the age of 20 years. Splenic sequestration. So there will be a high number of the sickle cell which will be trapped in the large amount in the spleen. That will cause acute enlargement of the spleen with severe abdominal pain. There will be drops in hemoglobin level, causing the patient to be hemodynamically unstable. So then there will also intrahepatic sequestration in the adult. We have said about multiple organ disease damage, mostly to the fact of continuous vaso-occlusive crisis causing microinfarct to the organs. So we have skeletal involvement. We may find osteonecrosis. And then we find organ failure. You may find spleen vaso-occlusion, which lead to splenectomy, long heart, cardiomyopathy. So all these are just secondary events due to chronic infection of microthrombus. We have also a second complication, which are secondary plaque crisis, which is caused by decrease in hemoglobin and reticulocyte counts, which also decrease in the white blood cell and platelet count. Usually it's self-limiting, but sometimes the association with parvovirus B19. So gallstone, it is because of a chronic hemolysis, there will be increase of bilirubin causing gallstone, but also leg ulcers due to infection, ureter infection. So poor oxygen supply. So I've said about the vascular necrosis, and hyposplenism, which are the issue now. So poor prognosis important is usually when the patient is presenting with increase of white blood cells or decrease of hemoglobin B7, elevated LDH, and low fetal hemoglobin, and also hand syndrome below when the patient is below 1 year. That is a factor of poor prognosis. How to make the diagnosis of anemia? Normally, in the country where there is high suspicion of sickle cell disease, they do the diagnosis, especially in they do screen so that you can identify people with sickle cell trait, and then them to get married to someone who is not sickle cell trait. So that helps them to decrease also the number of sickle cell. Not in South Africa, it's not really automatic, the screening program. So high index suspicion is usually from people coming from West and Central Africa, Nigeria, Angola, and so on. Children with one of the parents from one of the body, the patients presenting pain, pallor, and anemia. So how do you get the history? How to ask the mother if there is a history of blood transfusion in the past, if there is a history of joint pain and bony pain in the past. So that's how you make the diagnosis, and the history should be focusing on the future of the transfusion history. Any member in the family having the same symptom will also have additional values. Still on the diagnosis, the full blood count will be showing anemia with the high lymphocyte count. Why? Because there is the hemolytic process causing increased red blood cell production. There will be also feature of hyposplenism. As I told you, the spleen is there to do collection and remove of abnormal cells or aged cells or damaged cells. So in case of sickle cell, there will be a functioning of spleen, making the spleen making those abnormal cells keep circulating. They also have for the key exam, which is hemoglobin electrophoresis. So it's a gel electrophoresis which will show of hemoglobin move at varying speed. So here again, it's the key to show how long is the percentage of hemoglobin A, hemoglobin S, hemoglobin. So that will be the diagnosis showing that for sickle cell anemia SS, the hemoglobin S is even above 50%. So it is. You can do full blood count and so on. The smear you may miss. Smear not already found the sickle cell. You may miss it if the patient is not in active hemolysis. Then you may see antibodies of autoplenectomy. So those are just repetition about the hemoglobin chain, alpha, hemoglobin A1, hemoglobin A2, hemoglobin hemoglobin, and so on. So normally in adults, in infants, you have hemoglobin F is 50 to 80% at 6 months. Hemoglobin F decrease. That's why I said the sickle cell is somehow not visible or manifesting at the age below six months, because at this age they have high fetal hemoglobin, which that contain hemoglobin beta chain. So that's why they are somehow protecting the symptom of the. It's when they're above 6 months that the symptoms start to occur. In adults, you have hemoglobin A is 95 to 85. 98. Hemoglobin A is 2 to 3. Hemoglobin F, fetal hemoglobin. Hemoglobin S, hemoglobin see 0%. Then you will see it is an hemolytic anemia, but cum test will be negative. You have to do also some hemolytic panels, LDH, aptoglobin, and so on, just to do more on your test. That is describe hemoglobin electrophoresis. So how will be the management? The only possible cure is to do bone marrow transplant, but for this you have to consider how to get the donors, how to get financial, how to get sibling, because maybe the sibling may also having sickle cell diseases, so it's all crucial how this. So normally for sickle cell management, they should be having a clinic where the patient with the sickle cell disease will be coming at a regular basis over the year for clinic. They need to do genetic counseling where you have to screen from the. If you find someone with sickle cell in the family, you need not to stop there, but also to go to do deep analysis to find who is a carrier. So we get contact rate in the family member so that you decrease the rate of propagation by limiting a number of marriage among people with sickle cell trait and so on. You have also to do patient and family education. They should be knowing how to assess the spleen at home, how they can know how to hydrate the patient, what stress are to avoid, how to avoid them. So all this should be discussed with the patient. You have to monitor their growth. We have about immunization again. They have a lean hyperfunction, so remember to discuss with the vaccination, infection prophylaxis, and as they have a chronic, they have a chronic hemolytic anemia, they should be put on folic acid supplementation. So another treatment for long term is to give hydroxyurea. Hydroxyurea, how does it work? Usually it causes myelosuppressive effect of the erythroid precursors, so is a precursor of erythroid to decrease. Then to stimulate the production of a new red cell, which will be having more fetal hemoglobin. So there will be increase of fetal hemoglobin at this stage. So how do you give it? It causes increase of fetal hemoglobin, release of nitric oxide, and decrease of white blood cells, and increase the number of episodes of pain, and so on. So this is how hydroxyurea can be given and indication of them. So hemoglobin below 7, chronic hypoglycemia may start by 20 mg daily and decrease by 5 every 2 months. Yeah, then you have to monitor the response progressively. So other things is to consider is to consider the complication like cerebrovascular accident by monitoring the patient, by doing some investigation like like EKG, lung function, and so on. Monitor the bone X-rays and so on. Then the patient may also be put on transfusion where they'll be getting blood transfusion every 2 to 4 weeks, especially if they have severe rickets chain syndrome. So is this list show you who can come in the chronic transfusion where they'll be getting blood transfusion every 2 to 4 weeks. Then we also consider splenectomy if there is splenic sequestration, cholecystectomy when there is gallstones. Then we have to consider some special consideration when the patient is requiring general anesthesia, because general anesthesia may be associated with the acute cell syndrome, may also have something to consider done to transfuse the patient due to hyperviscosity and so on. So teach the patient to assess the fever, which is a medical emergency in case of infection. There will be a high risk of having sickle cell crisis, vaso-occlusive crisis. So infection is high during in this patient, so consider also treatment of the infection as soon as possible. Early crisis should explain to the patient how to manage the pain at home by starting by the hydration and rest and analgesic. Avoid stressors like emotional stress and so on. In the hospital, when the patient is there, you have to screen for targeted organ which can be affected by infection. So remember again, IV fluids, full blood count. You do the infection workup. So acute syndrome will be usually investigated in a tertiary hospital because it can also mimic pneumonia or fusion. It's also by considering other markers. You may not decide to do CT scan as it's not indicated. You may screen for infection to make sure that you're not missing pneumonia. But as I said, you also have a infiltrated chest X-ray, even a fusion. So it's somehow not easy to differentiate chest acute pain to chest infection like a pneumonia and so on. So for the spleen sequestration, it's a medical emergency. They'll need to stabilize the patient hemodynamically. You need to transfuse urgently the patient with the blood group O negative, but also you have to monitor the spleen size, you have to monitor the vitals and the transfusion and so on. Again, you have to consider splenectomy if there is a spleen sequestration. So this patient may also have high risk of developing adrenal events like stroke and so on. You should be asking for the CT scan, MRI. Then you also do a filtered packed red cell to reduce hemoglobin S level and decrease further damage. So these are the things to consider. So mortality and morbidity mostly because it's an issue in our setting. I can say most of the patients are seen in pediatrics between the adult age. We don't see them a lot in the internal medicine, meaning that still the mortality rate is high in our population. So like in Nigeria, 100,000 of babies are dying per year in Nigeria. So the cause of death may be either acute chest syndrome, pulmonary embolism, infection, or cerebral vascular accident. So this is a high complication. Then, by using the access to the vaccination, they found that there is a decreased mortality by 82%. Then, Tascania Doppler may also detect the risk of a stroke and address it as soon as possible. Uh, let's to the last topic on the anemia. So I'm still finding how to share the documents. I'm sorry for a short minute. I think you can see the slide now. So there's one chapter on thalassemia which is missing, but we can make it tomorrow. Let's jump to the disorder of the white cell. If you have any question, you can ask meanwhile on anemia, or we can keep it and ask it after everything tomorrow. So disorder of granulocytes and monocytes. So we have Hello, are you getting me?
Yes, lecture.
Are you getting me? Okay. So we
Yes.
have disorder of the white cell, which are binary. We have just a quick introduction. We have two groups. We have phagocytes and immunocytes. So among the phagocytes, we have granulocytes, which are neutrophil basophil. We have granules in the cytoplasm with monocytes that give phagocytes. Then you have only mature phagocytes and lymphocytes are found in the peripheral blood film. By understanding their role, they protect against infection. Then it's usually connected to with two soluble protein system, which are really complement and immunoglobulin. We'll discuss more on that small immunology. You should also understand the differential of white cell count. If they give you white cell count, you don't need to stop there. You have to go deeper and assess which white cell is involved. Is it a neutrophil increase? Is it a eosinophil and basophil? Something like that. Then you should also understand that the counts comparing adults and children, the counts are not the same. You may call normal white cell counts in childhood, calling it upper leukocytosis. So again, the range depends on the age of the individual. So the normal white cell count is 11 to 4 to 4 to 11 times 10 9 per liter. Then eosinophil is the most predominant, occupying 40 to 80%. Then come lymphocytes, 20 to 40%. Then you have monocyte, you have eosinophil and basophil. We have the absolute count, which is there as reference. This is in the children. We have like in neonatal, where the count is increased 18 to plus minus 80. So you may see even a baby with a 26. So don't call it abnormal. Just consider the value depending on the age of the patient. So for leukocytosis, we have the count above 11, meaning that it is increasing count. We have leukopenia when it is below the normal range. Neutrophilia, when the count of neutrophil is above the normal range. Neutropenia will be the opposite. Lymphocytosis, when the count is above the normal range, and opposite are in lymphopenia. Eosinophilia, when the count is above 0.6, and monocytosis and basophilia. For these, we only consider the increased number because the decreased one do not have any useful signification. Secondly, we have granulocytosis, which is decreased number of or incomplete of granulocytes. It's usually drug induced. We have then leukemia, which literally means neoplastic or malignant proliferation of the white cell, not only white cell, but also white red cell and uh, platelets. Function of the neutrophil and the monocytes, you have done it in my physiology, histology, and so on. Cause of neutrophilia, we all know bacterial infection, inflammatory diseases, neoplasma, acute hemorrhage. What I want to insist here is to insist on the steroid used when you put your patient on steroid. Uh, then you realize that the white cell count is increasing. Don't call it infection. So steroid can induce increased production of neutrophils, making the count to be higher.
Question.
Yeah, please.
Slide is not changing.
Sorry?
Slide does not change.
No. Can you see the slide now?
Yes.
Okay, so I was saying that steroid use may induce also decrease cell production, increase neutrophil production. We have also treatment with growth factor may also increase the count. The mechanism just increase production from the bone marrow with accelerated release from the bone marrow in the bloodstream, so there will be increase of the number. Neutropenia decrease the number below 2. Then we have 3 grades depending on the severity and the risk of getting infection. We have a mild 1 to 1.5 with no risk of infection, moderate 0.5 to 1 with mid risk, severe below 0.5 with significant risk. So again, you have to classify your patient depending on which grade they have. Cause of neutropenia, it includes infection, especially HIV, TB, miliary TB, typhoid fever. We have also medication like chloramphenicol and some anti-inflammatory agent and so on. We have immune causes like systemic lupus erythematosus, HIV, but you may also have any other cause of plastic anemia in case of plastic anemia, malnourished and so on. This may also affect the neutrophil production. Splenomegaly from any causes. Granulocytosis in all, like most of the granulocytes will be decreased. Then you have familial or ratio where you may see family members with decrease of neutrophils without any other issues. We have also congenital congenital neutropenia. We have a feature of neutropenia, mostly the patient presenting with severe neutropenia, coming with infection. Infection can be localized in part of the body, so mouth, skin. They may have a septicemia, with different germs, even from the virus, Hepatozoster. They may have a fungal. They may have a parasite. So any kind of infection can be considered. So how do you treat it? You have to treat it with the antibiotic, antifungal, or antiviral. We can also give a prophylaxis antibiotic agent when there is a severe neutropenia. We have also to consider treatment with antifungal by giving fluconazole. We have also mentioned that some medication can cause neutropenia. If it is the case, when you withdraw the medication, the count may normalize within 1 to 2 weeks. Let's go to neutrophilia, eosinophilia now. It's a count above 0.5 times 10 times 9. We have tropical eosinophilia, which is mostly seen in allergic diseases. We see it in asthma, urticaria, in case of parasitic infection, skin diseases, in neoplasma like Hodgkin diseases, in leukemia. You may see people with increase of eosinophil. The last condition is what we call hypereosinophilic syndrome, which is persistent eosinophilia above 1.5 over the 6 months without any explanation, so without any identifiable causes. This may have been associated with some organ involvement like heart, lungs, CNS, GIT, and so on. Clinical manifestation was described like rashes, fever. They may present with the peripheral neuropathy, but when you go to the laboratory, you find that the neutrophil count is extremely very high. You see the count of hundreds, so it's really a very high eosinophilia. When you go for histology, you may see some feature for acute arteritis, pericarditis. So with this condition, most of the time is associated with some underlying condition. So the treatments, it may work with corticosteroids. It may also treated by hydroxyurea, which will be decreasing the number of the count. Will decrease the number of the cells. So basophilia, when there is increase in basophil count, it's usually seen in case of chronic myeloproliferative disorders, which is either in chronic myeloid leukemia. Leukemia can also affect the basophilic line, causing increase in basophil. They may also be seen in IgE, allergic disorders, ulcerative colitis, or hypothyroidism. So the treatment is to consider the treatment of the underlying condition. Monocytosis, again, it is increase of the monocyte above the normal range. It's usually due to infection like a TB, like typhoid fever, malaria, in case of trypanosomiasis, but also it might be seen in the case of hematological malignancy where the leukemia is now in the line of monocyte, acute myelomonocytic leukemia, acute monocytic leukemia. So also in myeloproliferative disorders can also see that one. Other condition may be in the case of sarcoidosis, ulcerative colitis, or post-chemotherapy. Again, the treatment should depend here on the on the cause. So for the lymphocytes, details disorder of the lymphocyte will be seen in the course of immunology, but increase of lymphocyte above the normal range. Most of the condition is due to viral infection. Example, in case of infectious mononucleus due to Epstein-Barr virus. We have rubella, we have CMV, and so on. It may also be increased in case of hematological malignancy, which is acute lymphoblastic leukemia or chronic lymphocytic leukemia, or in case of lymphoma. Increased lymphocytes also may be seen in case of thyrotoxicosis. So sometimes when you see lymphocytosis can occur in children as response to bacterial infection, while in adults, bacterial infection produce neutrophil leukocytosis. So in children, seeing increase of lymphocytes, it may also be bacterial infection. So that don't consider the increase in lymphocyte mean only increase bacterial infection or viral infection. So we have a common cause of lymphocytitis. We have ABV, pertussis, and HIV infection. A little word on mononucleus, infectious mononucleus, which is an acute infection caused by ABV virus. The transmission is usually based from the transfer of the saliva from the affected person to normal person. It usually manifests in few of the cases, and most of the condition is subclinical, so the patient may not present symptom, but sometimes they present an expression of T cell which is reactive to B cell lymphocyte which are affected with ABV. So how is the symptom? The age is usually between the young adolescent and adults. Incubation period is around 3 to 8 weeks. Then the patient may present a feature of a sore throat, malaise, lymph nodes. They may present oral and pharyngeal surface inflamed, but 50% may present with splenomegaly, jaundice in 5%, and hepatomegaly in 15 of the cases. So the other manifestation, apart being a hematological manifestation, they may also be having peripheral neuropathy in Bell's palsy. They may also present as a Guillain-Barré syndrome, encephalitis, myocarditis, and so on. How do you make the diagnosis? It's usually by going to the peripheral blood film. You may see what we call increase in lymphocyte with atypical lymphocytes. Atypical lymphocytes are the lymphocytes which has very large cytoplasm with the cytoplasm which is somehow irregular. So maybe if you have chance, we can show you what we call atypical lymphocyte. They might be also associated with neutropenia, thrombocytopenia, or autoimmune hemolytic anemia, which may also occur. So how is the test done? You go and look for the antibody to ABV. Case of lymphopenia, meaning the number is below the normal range. For that, you have infection, you have chemotherapy, aplastic anemia, steroids, and so on. Those are the cause of lymphopenia. So lymphopenia usually also are present in the case of HIV/AIDS condition. So little reminder about the hematological manifestation of HIV. It's occur when there's advanced HIV infection, especially When the CD4 count is below 0.2, that's when there is high risk of developing anemia and thrombocytopenia. Thrombocytopenia can be due to immune or to the bone marrow dysfunction. For HIV infection, the bone marrow might be hypercellular with increase of lymphocyte and plasma cell. It might also be normocellular or hypocellular. So meaning that there's no a characteristic feature of the bone marrow in case of HIV/AIDS. But the marrow examination will help you to make the diagnosis of some opportunistic infection like TB, like atypical mycobacterial infection, and so on. But consider also in HIV, they use some retroviral treatments which may interfere with the metabolism of folate, like AZT, ganciclovir, trimethoprim, and so on. So those may cause the folate deficiency. Other manifestation of hematology in HIV, the mechanism of anemia in HIV is somehow multifactorial, where we describe the impact of having opportunistic infection in HIV by the mechanism of anemia of chronic disease. That one. Secondly, we have the effect of HIV itself on the bone marrow microenvironment. They say the infection of bone marrow by HIV cell itself may cause also anemia. We have some non-specific antibodies causing hemolytic anemia in HIV. Then in advanced HIV condition, you may have lymphomas, malabsorption, TB, and so on, causing also anemia, but also micronutrient deficiency in case of poor nutrition when there's advanced HIV. And then we consider also the medication taken during the disease course. How do you improve hematological parameters? In the past, as I said, they used to give treatment, antiretroviral treatment, when the CD4 count is somehow very low. But now, if you test HIV positive, you have to start the antiretroviral treatment. So that's even the prevalence of anemia in HIV has somehow decreased. So we have seen a response to antiretroviral treatment where anemia improved by itself without giving any treatment. So the treatment of that is usually supportive, and supportive it aim usually to preventing and treating the opportunistic infection and some viral infection by source. So treating by antiretroviral treatment supports the condition. So thrombocytopenia, mostly it's immune induced. You can give steroid or IV immunoglobulin plus retroviral. Then if there is a lymphoma, the patient can be treated as required by the chemotherapy as requested by the treatment plan. So that is all for benign disorder of the white cell, but I've tried to combine also by the format, just mentioning them. And so, any question on that? Any question? So if there's no question, we can go to other issues. So now we are going to start malignant hematological malignancy, where we talk on leukemias, we talk about lymphoma and multiple myeloma. These are the big classes of hematological malignancy. Are you getting me?
Yes.
Okay. So by leukemia is a Greek name which means blood cancer. Then usually they call it cancer of the white cell, but by these days there is no, leukemia can not only affect the white cell, it can also affect platelets and red cells. So it is a broad term covering spectrum of the diseases, where in 2000, that is a long time ago, 256,000 children was having leukemia, and among them 209,000 died from it. So when you see such number of death, it means that period, the mortality due to leukemia was really very high. About 90% of leukemia are diagnosed in the adult. So when you are dealing with the leukemia, you need to classify leukemia. How does leukemia is classified? We have first in the mechanism of the disease, we need to say, is it an acute leukemia or it's a chronic leukemia? Let's start by acute leukemia. So in acute leukemia, there'll be a rapid increase in immature cell production. So the immature cell production lose the capacity of maturating. They stay immature status. Then the bone marrow will be full of immature cells. The bone marrow will not be able to produce any line of the cell. So there will be decrease in hemoglobin, decrease in mature white cell, then decrease in platelet production because the bone marrow will be hypercellular, busy producing immature cells, which is no longer maturating. They lose the capacity or they have maturation arrest. So the bone marrow is unable to produce healthy cell. The treatment must be immediate in case of acute leukemia because if you don't treat the patient very quickly, the patient may pass away within months. So it's the most common form of leukemia in childhood. So most of the children present acute leukemia. Let's go to the chronicity. So the chronic leukemia, it's an excessive breakup of relatively mature cells, but despite being mature, they are still abnormal. The disease takes months to year to progress. Then the counts are produced at much higher than the normal. Then that results to the abnormal white blood cells, abnormal cells circulating in the past. But also, it mostly occur in the older age, but it can also occur at any age group. So comparing the acute and the chronic one, a chronic one, the cells are maturating, but they are produced in high number, but there is also prolongation of the lifespan. There is an issue with the apoptosis. Cells spending long time compared to the normal lifespan. Then the disease progression in acute leukemia, it's acute like birth. Then in chronic one, the process may take months to years to develop. The second division now depends on the type of the cell which is seen. leukemia can be on the lymphoid progenitors, being lymphoblastic leukemia or lymphocytic leukemia. Then it may also occur in the myeloid, being myelogenous leukemia or myeloid leukemia. So when I say myeloid leukemia, understand all the cells apart the lymphocytes. That is acute myeloid leukemia. So the most of the acute, when I say ALL mean acute lymphoblastic leukemia. When I say ML, we understand acute myelogenous leukemia. Most of the ALL are mostly from B cell. So myelogenous leukemia occur in white cell, but also platelets and red cells. That's what you have said. So by definition, ILL, it's either acute childhood leukemia, or cancer acute childhood leukemia. So it is usually a progressive malignancy diseases, which is characterized by a large number of immature cells, which are called lymphoblasts. So the bone marrow will be the one producing the cell, but the cell also should be going to the lymph node, the spleen, or other organs. So it represents usually 80% of the leukemia in the childhood. The age is between 3 to 7 years. Then it occurs only 20% of leukemia in the adults. So as we said from the beginning, in acute leukemia, the cells lose the capacity of maturating and differentiating. By this, they stay immature, they lose their normal functioning. So those cells multiply quickly and they replace the bone marrow cells, which are who are supposed to be red cells, platelet, and so on. So the bone marrow will be full of these immature cells, which are lymphoblasts. So when you see in this, so when the bone marrow is replaced by those immature cells, there will be poor production or decreased production of the blood, of the platelet, that will be leading to bleeding. There will be decreased production of white cell, that will be predisposing the patient to get infection, because there will be decrease or absent neutrophil because there's no maturation. So what are the risk factors? Most of the factors are not apparent to cause the leukemia, but it's somehow associated with radiation. It may associated with radiation, exposure to toxin like benzene, chemotherapy agent, but also chromosomal abnormalities may also have been playing a role in acute leukemias. So maybe I can do like this. So you see here, I'm going to explain the two things at the same time. You see the hematopoietic stem cells, which has the capacity to produce differentiated cells. You have lymphoid progenitors, you have myeloid progenitors. So when there is a acute myeloid leukemia, there will be maturation arrest from here. So from here, there will be no longer maturation. So this mature cell will not be there again. That is acute myeloid leukemia. When there is a lymphoid one, there will be maturation arrest at this stage. So the cell will be no longer maturating to the mature lymphocyte. So either it is a acute myeloid or acute lymphocytic or lymphoblastic leukemia. All this is on the precursor cell, on the earliest cells, which are lymphoblasts in in lymphoblastic leukemia, or which is myeloblasts in the case of myeloblastic leukemia. So that can you see the slide now? I somehow adjusted.
Yes.
Okay. So that is lymphoblastic leukemia, where the lymphoblasts can not longer go to the maturation. So how do we classify it? We classify it according to two things. We have morphological classification, we have immunophenotypic, and we have cytogenetic classification. Because I can say even more than 70% of the leukemia has genetic abnormalities or chromosomal translocation or something like that. So there's a classification of French America British, which classify the acute leukemia on the morphological.
Sorry, spider not moving.
Which one are you seeing?
We are still on 11 9. Yeah,
Classification?
yeah. That one
Classification?
contain picture.
Sorry?
That one contain picture.
Oh,
It's number 10.
okay.
Yari yageze kuri
Can you see it?
Not yet.
Oh. Can you see the slide now?
Yes.
So I was explaining that in French, American, British, they classify it based on the morphology of the cell you see on the microscope, on the blood cells. So we have L1. They describe the lymphoblast which is in there. They say small to medium size with high nucleostoplasmic ratio. High nucleostoplasmic ratio means that you have a high nucleus with very small cytoplasm. Then you have the delicate chromatin pattern, which has small nucleoli, which are not very conspicuous. I will show you the picture. Uh, the cell look like this. It look like a small lymphocyte, but when you see inside, you see a nucleoli. Normally, mature cells do not have nucleoli. So when you see nucleoli, it's like it's immature cells. Bone marrow is really full of those cells which look the same. You don't see any progenitors of the red cells, any progenitor of the white cell, and so on. Or progenitor of the megakaryocyte. Then L2, it's a medium-sized to large pleomorphic blast, which is plentiful cytoplasm and prominent nucleoli, which is here. You see where the nucleoli are nucleoli is somewhat prominent. You can see inside. That is L2. L2 again. Now we have L3 showing cytoplasmic basophilia with cytoplasmic vacuoles. So L3 has vacuoles showing things on the cytoplasm are the vacuoles. So that is vacuole scenes. We have L3 in vacuoles, which is seen the cytoplasm. We can see it from far. This is the summary of what we have it. So L1, L2, and L3. But this is for someone who has specialized in hematology. For your level, you don't need to know these details. So how someone with leukemia will present to you? What are the clinical manifestation of leukemia? Who can tell us briefly, so I can hear if you are following? Who can tell us the manifestation? When you listen the pathophysiology, what is going on? How someone with leukemia present to you? Who can tell us briefly?
There are signs of anemia like fatigue, and tiredness, and even signs of thrombocytopenia like bleeding, and even signs of neutropenia like fever or signs of infections.
Good. So again, there is thrombocytopenia, bleeding, uh, decrease of neutrophil infection, then future of anemia. Those are the three things to understand in summary. So this table classify the signs depending on the origin of each. So risk of infection by PCP, fungal, and so on, bleeding all over you may have bleeding from the mucosa, from the gums, and so on. So again, that's summarized. So you see quite, it's not somehow the same with aplastic anemia, the symptoms. But here again, here most of them, they may have lymphadenopathy, which is not seen in aplastic anemia. So people may have purpura, they may have hemorrhage in the mouth, they can have express zosters. We have bone marrow failure with anemia, bruising, lymphadenopathies. They may have a bone pain, sternal pain, joint pain, mediastinal masses, and the leukemia can also infiltrate in the CNS, in the testes, and so on. Let's go to the laboratory now, the full blood count and the peripheral blood film. There will be feature of anemia, thrombocytopenia, and neutropenia. The white cell count most of time is very high, but you may also see normal or decreased count, which is somehow not common. You will see the circulating blasts. As we said before, only mature cells are found in the peripheral blood film. But in case of leukemia, you may see some lymphoblasts in the peripheral blood film. So those are somewhat suspicious of leukemia. Coagulation panel may be abnormal. There is high risk of having intravascular DIC, disseminated intravascular coagulation. You go to the bone marrow aspirates, you'll see increase of blood cell. By definition, leukemia is defined when you see in the bone marrow lymphoblasts or myeloblasts above 30% of the cell. Normally, the blasts are below 5%. 5%. When you see the blasts above 30%, that fit the definition of acute leukemia. Useful, the bone marrow may be hypocellular or fibrotic. So you have to do morphology to describe the cells which are seen. We have immunophenotyping. We have also cytogenetic, which will show you which cell translocation is seen. For example, in case of Philadelphia chromosome, which is a mutation between long arm of chromosome 9 and chromosome 22. There are some cytochemistry which was done before, but now there are new technique which is easy to use, which we'll call it immunophenotyping by using flow cytometry. You can give your cytochemistry very care on when the technology was somehow not efficient, where you should go and stain the cells and so on. PAS, which is a periodic acid shift reaction, it was positive in case of acute L1 lymphocytic leukemia, but it's not specific to allergy. So it was not specific, you can miss it. We have the one now saying it is immunophenotyping by using flow cytometry. So flow cytometry usually it's a technique which uses the study of the protein expressed by the cells. Then each white blood cell has antibodies which directed against the surface protein in the membrane. So we call them monoclonal antibodies. So the technique is using monoclonal antibodies markers through the flow cytometry, which is a laser-based instrument which can analyze thousands of cells per second. So it can use the blood, can use the bone marrow, spinal fluid in a few hours. So the cells which are there are expressed by monoclonal antibodies, which is called a cluster of differentiation. So leukemic cells of ILL are positive for CD10, CD19, and TDT. So those are the specified technology which we are not going to go deeply in that at this level, but understand that the flow cytometry do use the antibodies which is retargeting the antigen on the cell expressed by leukemic cells. So when you see that CD4 is CD10 is positive, CD19 is positive, so that one it's classical for acute lymphoblastic leukemia. And then when you see when it is T cells, CD10 will be negative, 19 will be negative, and TDF will be negative. So that will be T cells. B cell will be positive for CD19, but not CD10 and TDT, so which are somehow specific. So when you go to cytogenetics, usually the branch of genetic which will give you the structure of specific chromosomes. You may use G bonds, or you can also use fish, or you can also cooperative genomic hybridation. The purpose of this is just to see if there is any chromosome abnormalities, because there are some chromosome abnormalities which predict to poor prognosis or to orient you to the treatment options. So, for example, in acute myeloid leukemia, promyelocytic leukemia, there is a translocation between chromosome 15 and 17. When you see such mutation, translocation, it give you to know that the prognosis is good, but also which treatment option should be considered. So the purpose of doing cytogenetic for the diagnostic purpose, but also for the prognosis and the treatment option also can be oriented. For example, for Philadelphia chromosome, the Philadelphia chromosome has tyrosine kinase activity, making the cell to produce in controlled level. But when you see that you are going to target the treatment on giving tyrosine kinase inhibitors, so again that helps you to focus on that. So how is the treatment of acute leukemia? The goal of the treatment is to get remission of the cancer, meaning that you have normal peripheral blood, but also normal bone marrow. The counts we see for the blast, which was more than 30. Sometimes you can see all the cells are only blasts in the bone marrow. So when the cell should be coming to the normal range, but also when the full blood count come to normal without anemia, without thrombocytopenia. So chemotherapy can take 3 to 6 weeks to the hospital, when the patient may have a combination of prednisolone, vincristine, cyclophosphamide, and so on. Then the reason why I don't give you details here, it's just because the guidelines are most of them revised. Then the treatment option can also depend on the setting where you can see this is expensive. You develop your guideline locally and you adjust the medication line. Apart the chemotherapy, you need also to give a supportive medication, which usually consists of pain management, blood product transfusion, correcting the anemia, correcting the thrombocytopenia, so that the patient cannot have a major bleeding due to severe thrombocytopenia. Again, remember, acute leukemia, the patient is highly exposed to have high-risk infection, so giving antibiotics will be preventing or treat infection. So we have details in the conduction, we have consolidation and maintenance, which may have even up to 3 years you are treating leukemia. So induction, so vincristine, steroid, and asparaginase. We have consolidation, and so on. Then we have maintenance. You have to keep the patient on PCP prophylaxis and keep them in the hospital with the high infection prevention control, where the patient cannot be exposed to infection. In very good center, they used to be isolated, where entering in the room should be restricted only for personnel and some specific consideration. So outcome, in developing countries, 80% of the cure rate is in all, but there is a high risk group. Then several less intensive approaches have been tried in the poor resources, where within 20 to 70 cure rates can be found. So depending on which support we have to your patient, I say we have supportive treatment, but also some logistic like isolation, center for getting platelet transfusion quickly, uh, better choice of chemotherapy drugs. So all this should be assessed. Nutrition status: when you are giving a chemo, the patient should be well nourished, if it is a protein intake, if it is. So sometimes the patient here may not get all this necessary to facilitate the cure. So the cure is somehow depending on that. So after the remission achieved, chemotherapy or radiotherapy can be administered if the leukemia has affected the spinal column, but also you should direct preventing relapse. Relapse means that the patient has get remission, then again after 1 year he came back again with the future of leukemia. Sometimes the patient may not respond to chemotherapy, or they can relapse after high dose of chemotherapy. So again, that better choice will be to give bone marrow transplant. So bone marrow transplant for leukemia is not given as the preliminary as things to start by. It usually starts by chemotherapy. When it fails, that's when you see the rate of giving bone marrow transplant. But also you consider genetic aspects. The outcome of all this should be assisted. Next, prognosis in children, especially, it's better than the adult. The cure rates is usually 80%, with achieved completion of 30 to 50% being cured. But when the disease is late, without treatment, the life expectancy is around 3 months. So meaning that if you take longer to consult, most of our patients reach our center after 3 months. So they spend days in the district hospital treating like infection, coming here. So most of the time the mortality is high, either due to late diagnostic, late management, and so on. So as we see, it's really a severe condition. Without treatment, the life expectancy is very short. So what else we have to say on prognostic factors comparing IML to ILL? ILL, when the age is below, that is poor prognosis, below 1 year, and IML when the age is above 60, that's a factor of poor prognosis. When the total white blood cell is higher, is above 50 in acute lymphoblastic leukemia or high in IML. When there is a CNS involvement, that's also poor prognosis. Or for ILL, when it is a male, prognosis is not good. When it is male or female, for IML, there's no difference. Cytogenetic ILL, when it is 9 to 22, that is poor prognosis. But when it is a monosomia 5 and 7, that is poor prognosis for IML. Then cure rate is better in ILL than IML. What are the complications of anemia, of leukemia? Most of the complications are usually either disseminated intravascular coagulation. This leukemic cell has high potential of producing the cytokines. Then the cytokine may induce the liberation of tissue factor in the bloodstream, causing the initiation of disseminated intravascular coagulation. There is also a risk of relapse. So the patient may get remission, then gets infection. Severe infection may also kill the patient. So how do you prevent acute leukemia? Most of the causes are not known, so it's not easy to prevent it, but at least we try to focus on minimizing the exposure to radiation, exposure to toxin. When you don't know a product, don't go and manipulating that one. There are studies which have shown that people who do rehabilitation of the house when they're inside, for example, you are painting your house, you are changing some material in the house while living there. The study showed that there was high number of the leukemia among the children, especially children living in the house where people are doing rehabilitation. But also those insecticides where people use in the house, in the garden, in the where they're having agriculture like vegetables, putting that product is also not safe. So they try to minimize any chemical use and so on. Uh, Acute myeloid. Any question on acute leukemia, acute lymphoblastic?
How can they say I have not understood where how they say I complicate acute leukemia.
Sorry?
I have not understood very well how the CI complicate leukemia. DIC, I mean.
So I said that those leukemic cells producing a high number of cytokines. Then cytokine may induce the liberation of tissue factor. You remember the cascade of coagulation? The intersect part of coagulation, do you remember?
Yes.
So it may induce the liberation of tissue factor in the bloodstream, causing the activation of coagulation cascades. So then that will cause DIC, which will mean consumption of coagulation factor and platelets. Then there'll be, we discuss more on the mechanism of DIC, but usually it's just the consumption of the coagulation factor and platelets, which will be manifested by bleeding and clotting together. There'll be derangement of the fibrinolysis. That's explained in the process.
Okay.
Mhm. Yeah. So, let's go for quickly. Maybe we stop at 5, but let's start a little bit on acute myeloid leukemia. It's almost mechanisms are the same, so we are going through it quickly. Acute myelogenous leukemia or acute granulocytic leukemia or acute non-lymphocytic leukemia. Uh, These two are the cancer of blood-forming tissue of the bone marrow, which are the same, characterized by the growth of immature blood cells, which lose the capacity of maturating. The bone marrow will be full of those immature cells. It will be enabled to produce the rest of the cells. Then you have categories of the type of leukemia. We have classification from French, America, British, again based on the morphology of the leukemic cells which is seen. We have M1, M0 to M7, so 5 subcategories. So AML can occur at any age, but primarily affect the adults and the children at young age than 1 year old. The disease is the same, is immature cell lose the capacity or ability to mature and differentiate. The cell multiply rapidly and replace the bone marrow. Then the bone marrow is replaced by the leukemic cells. That should be the same risk of infection, bleeding, anemia. So most of the causes are not apparent, but again, radiation, benzene, chemotherapy are the key. Then you have also genetic anomalies. So these are quite the same as the previous leukemia. It can also have a risk factor as a polycythemia rubra vera or essential thrombocythemia. People with myeloproliferative disorder may also present with and develop acute leukemia, myeloid leukemia. We have also myelodysplasia and so on. What are the risk factors again? We have genetic. People with Down syndrome have high risk of developing acute myeloid leukemia. Exposure to benzene, pesticides, cigarette smoking, and so on. Anthracyclic chemotherapy. So someone may have cancer of the stomach, akajya muri chemotherapy, akavayo agasanga arwaye leukemia. So leukemia can come after cancer therapy. What else we have to say here? The symptoms again, nicho kimwe. So decreased production of the platelets causing bleeding, decreased production, loss of maturation of the cell becoming immature, decrease of neutrophil, lymphocyte, risk of infection, and anemia. So this is the cross-cutting, they have the same. We have something which is specific to him. They have gum hypertrophy. You see the gum for this patient is really hypertrophy. This is mostly seen in case of acute myelomonocytic leukemia. You see how the gum is. The skin infiltration of the leukemic cells. Bone marrow failure, twabivuzeho cyane, leukemic infiltration of the tissue, CNS inflammation, gingival inflammation, lymphadenopathy. Ariko muri acute myeloid leukemia, most of the time the patient do not have lymphadenopathy compared to the acute lymphoblastic leukemia again, but not every time. You may find also people with lymphadenopathy in case of AML. Secondly, what I want to say, recently we had the case. It was a young boy, I think around 17. He had exophthalmia, so the eyes like somehow propped outside, like marked exophthalmia. He went to ophthalmology. Then ophthalmology, while assessing the patient, they send the patient to the brain MRI, brain CT, and the brain CT showed that there was a mass in the CNS. So when they saw the mass, they called the neurosurgeon. The neurosurgeon came. You see how important it is to do full blood count to every patient who is coming to you. It's better to do full blood count. So no one was doing full blood count since the patient was there. So before jumping to the brain, CT, whatever, start by the easiest. So when they did later on when they did the FBC, that's when they found that the patient was having severe thrombocytopenia with the increased white cell count and anemia. So when we went to the peripheral blood film, we found that the patient was having acute myeloid leukemia. So meaning that by looking at this future, the patient may present either with the gum inflammation, akajya muri dental units, akaza kugaruka iwabo, cyangwa se akajya no muri ophthalmology because leukemic cell can infiltrate any part of the body. So for classification of acute myeloid leukemia, we have M0 to M7, just depending on the type of the cells which is seen. We have M0, which are undifferentiated cells. M1, we have myeloblastic without maturation. M2, we have myeloblastic with maturation, and promyelocytic, myelomonocytic. From M4 to M5, we have monocytic cell leukemia. M6, we have erythroid now. So even the red blood cells are affected in case of leukemia. Then we have megakaryocytic leukemia, where we have now platelet also being involved. What we need to understand here, how do we differentiate some, as I said, lymphoblasts and myeloblasts, sometimes it's not easy to differentiate them at the earlier stage of this M0. It's not easy because myeloblasts have granules in the cytoplasm. Lymphoblasts do not have granules. But at early stage, when you say undifferentiated, the myeloblasts may not have visible granules. So to see the visible myeloperoxidase. Myeloperoxidase, when you do the stain of myeloperoxidase, it will show you that there is a granule in the cytoplasm. When there is granules, that time you say, oh, I'm dealing with acute myeloblastic leukemia. So we have type 3, M3, which is promyelocytic. You remember we have the myeloblasts, then after the myeloblasts, they make maturation to promyelocytes. It reached to the promyelocyte, then it stopped the maturation at the promyelocyte level. That's also what we need to understand. We have also genetic malformation, genetic abnormalities like T translocation between T chromosome 8 and 21, 15 and 17, and so on. That also may help you to know so. So for the differentiating between IML and ILL, most of time IML present with the gum hypertrophy, skin deposition. Then ILL have extramedullary involvement like CNS, mediastinal, lymphadenopathy, testicular involvement. Here we have extramedullary involvement is not common. Then you have hepatosplenomegaly, renal damage. DIC is quite the same, the both sides you may have it. Morphology, bone marrow and peripheral blood shows 30% increase of the blast. It's usually contain granules or inclusion called iron. When you see iron in the peripheral blood film in the blast, it completely you are dealing with acute myeloid leukemia. Ionic inclusion, like the granules coming together and forming a line, which is called iron. When you look on these slides, which type of islet do you have? Is it L1, L2, or L3? Who can tell us? If you are following. Any idea?
I think it is ALL1.
So it looks like LL1, so very
Yeah.
good. Yeah.
Mm.
So here again, you have to understand the differentiation of the two. So the blast size compared to myeloid and the myeloblast and the lymphoblast, the size are small here. Cytoplasm is scanty. Then you have nucleoli, which is indistinct, and chromatin is dense. You can't see very well inside. They don't have air present. Let's go to acute myeloblastic now. They have large cells. You see the large cells here. They have cytoplasm, which is moderate. They have chromatin, which is fine. You can see inside. You can see the nucleoli, which is blood whitish inside. Then they're somehow clear nucleoli compared to clear chromatin pattern. Then 50% of them will have iron. Iron is that line here. Can you see the line in red here in the cytoplasm with the arrow? Can you see it?
Yes.
So that one we call it iron. It's best seen in myeloperoxidase stain, but also when you see it, you confirm that you are dealing with acute acute myeloblastic leukemia. Secondly, I have said about myeloperoxidase. You use it when you want to see granules in the cytoplasm. Only it can make you to see granules in the acute myeloblastic leukemia because they're the one having granules. We have non-specific esters, which will be colorating M5, which is acute monocytic leukemia. We have PAS, B lineage, and acid phosphatase T lineage, which are specific to this staining. But now, for now, as I said, people are now focusing on using flow cytometry, which help you determine if the cells are lymphoid or myeloid. They use a class of differentiation, which is CD. IML is positive for CD13 and CD33, and negative of CD19 and CD20. Then M4 is positive for M7, which is megakaryblastic leukemia, is positive for CD61. So it's a Guerrero, the machine, they use those monoclonal antibodies to try to find out if it is a myeloblastic leukemia or lymphoblastic leukemia by using these markers. Ntabwo turabona iyo technology turafite ufite machine ariko we don't have reagents to use, but in near future we'll be using flow cytometry at CHK. In the country we have it at Lancet Laboratory, which is a private hospital. In the public we don't have any. So this is the panel we use, like CD13, 33, CD19, 19 negative. Then that is, you play this panel in the machine, it gives you more details. Then you go for cytogenetic. It also make you, we said that chromosome abnormality is found in 70% of IML and 90% of ILL. So doing cytogenetic will really help a lot. Those are the kind of the mutation which is seen commonly in case of leukemias. Other investigation, it's just to look for the location of leukemic infiltration. It may be in the mediastinomas. It can be in case of TLL, but also you can also do lumbar puncture where you can get leukemic cells which are involving the CNS. That is the chest X-ray finding mediastinal involvement in case of leukemic cell, TILL, and so on. So remember, when those patients come to you, they may also present future for tumor lysis syndrome, which is really increase of uric acid, phosphatemia, hyperkalemia, and hypocalcemia. They may cause acute renal failure, metabolic acidosis, and cardiac arrhythmia. They may also have a future for hyperleukocytosis or the dyspnea, chest, and so on. So let's say briefly about the treatment. The objective of the treatment is to get remission, which is to get the normal count, to decrease the risk of bleeding, but also to do supportive treatment by blood transfusion and so on. Platelet transfusion to avoid blood risk. So bone marrow transplantation again may be given except for the acute promyelocytic leukemia, which respond very well to retinoic acid. So the mutation between 15 and 17, it has a very good prognosis to the patient. They respond very well to ATRA, which is ultras retinoic acid. So M1 to M7 work with M3, so they need the remission, induction, and consolidation. M3 to quick-release tretinoin, and bone marrow transplantation. It's again given for failure to the chemotherapy or patient with poor prognosis, which may get it. So this table, you see it's just showing you the risk stratification depending on the different parameters, which explain to you if there is a high poor prognosis or what. So lower risk, I have hypodiploid or trisomic translocation between 12 and so that's why I was saying again, doing the cytogenetic help you to know the prognosis of the patient, but also the treatment line. Standard risk count of white cell count below 50, high risk count above 10,000 or age above 10, and so on. So we have more details on the table. So rate of remission is 80 to 80% of cure remission, complete remission, but only 20 to 30% will have survive of free disease from the diagnosis. So those patients who don't have relapse within the 2 years are considered as totally cured. So good prognosis is under 60. Without treatment, life expectancy is 3 to 4 months. Complications are the same: relapse, infection, and life-threatening. And how do you prevent it? Not easy, but we have to minimize the exposure to the risk factors as mentioned before. So what are the challenges we have in Rwanda in treating leukemia? Most of us, as I said, malnutrition. You are giving chemotherapy, but you don't provide adequate nutrition to your patients. That's the issue. We have delays in the interruption therapy, which increase the risk of relapse. Most of the patients come at delayed phase. Then we consider intensive therapy with the clinical and laboratory monitoring. We have transfusion support. We have supportive medication, which may not be available. That is again a major risk. So in Rwanda, we are only treating ILL. People with the IML are struggling. Those who can afford can go outside, but if you are not able to go outside, the government usually send you outside. But most of the patients, if they send you outside, you need to get the logistics yourself, like a ticket to India, tickets for your caretaker. So there are very few people who can afford those. So most of them, they go for palliative treatment like transfusion, pain management, and something like that. What else you have to say? In conclusion, on leukemia, ILL is the common cause of common childhood leukemia. Then it should be suspected when 2 or more lines are affected. So when you are working in the district hospital, you find someone with anemia and thrombocytopenia, among your differential, put also leukemia. So cure is possible for many children, but requires sophisticated diagnostic technique, which may risk approach with agent therapy over a long period of time. That's all for leukemia. I think we can stop there from today, and we continue tomorrow from 8:30. If there's any question, we can answer it. But if there's no question, we continue tomorrow. Any question? So I see there's no question. We go for tomorrow. I wish you a nice evening.